I'm Dr. Thomas Dayspring, the Director of Cardiovascular Education at the Foundation for Health Improvement and Technology here in Richmond, Virginia. Today, chatting lipids with two family practice colleagues of mine who are also certified in lipidology. Dr. Tara Dahl, who fluctuates between Wisconsin and Richmond, Virginia, and Dr. John West, who practices outside of Atlanta, Georgia. We have an interesting case we want to have a nice little roundtable with you today. You watching this will also see some slides that we're not looking at during this presentation. So friends, I want to discuss with you a 67-year-old non-smoking Caucasian woman who has been known to have an elevated Lp(a) level. She saw an endocrinologist who started her on atorvastatin 10 milligrams. But on follow-up testing, her Lp(a) actually jumped up from 150 to 226. I believe it was in millimoles per liter. Her past history is rather unremarkable. Family history shows her mom died young at 56, but it was of breast cancer. No statement about any heart disease. Dad died at age 99. Can't do too much better than that. Other family members do have high Lp(a) with some early heart disease. Currently, she's on no medication. The BMI is 24, and she is normotensive. Now, I will let the audience know this happens to be a case out of John's clinic, so he'll have some very special insight onto this. But when she showed up in John's office, this was the lipid profile, I guess, on the atorvastatin before it was discontinued. And it was a perfect lipid profile. The total cholesterol was 188, LDL cholesterol 84, HDL-C was actually 92. The ratios, total to HDL cholesterol, triglycerides to HDL cholesterol, were all perfect. Of course, for whatever reason, the endocrinologist stopped the atorvastatin. He was uncomfortable with the Lp(a) going up. And the profile off of the atorvastatin, so this is basically a baseline lipid profile in somebody with very high Lp(a), total cholesterol is now 220, LDL cholesterol jumped up to 125, HDL-C remains perfect, 89, triglycerides are 75, non-HDL cholesterol inched up from 94 to 131. Ratios remain good, but that is a 32% elevation of LDL cholesterol after atorvastatin. That's almost textbook for the type of drop you would have seen with atorvastatin or so. So, many issues to discuss here or so, but the first is Framingham risk scoring was done on this woman, and it's very low. So before we even get into the nuts and bolts of the lipid lipoprotein testing, what role does Framingham risk scoring have to play in the women? I'll let Tara take it, John, since it's your patient.
Yeah, so a Framingham risk score is a 10-year score. It's certainly not a score of lifetime risk for cardiovascular disease. When the American Heart Association published their guidelines in 2011 for women, they recognized that women actually have a very high global lifetime risk, and Framingham is going to miss that. So we need to do more than a Framingham analysis to really detect this risk in women, and certainly doesn't take into account a number of certainly parameters that are present here, the Lp(a), family history, that doesn't get worked into the scoring system. So we recognize that even just the elevated Lp(a) alone, puts this woman in a higher risk category.
So John, I don't think you could add anything to that. Just know how to use Framingham risk scoring in women and never dismiss a low risk thing. You don't know. If it's high risk, okay,
Right.
treat her
If
as
it's
high
over
risk.
20%, it means something. If it's less, it really doesn't.
And the important thing to know about women, it's right in that 2011 guidelines. If at age 50, and they list well over a dozen risk factors, if you have even one of those, the lifetime risk of a cardiovascular event approaches 50%. So. And some of those are not even traditional risk factors. They're a little shorter breath exercising or something like that. So John, initially you've had all this yourself. Does it surprise you that when he started his statin therapy, that Lp(a) certainly didn't go down, it actually went up? Is that to be expected, or certainly the endocrinologist was quite concerned, and I think appropriately referred to a lipidologist in this case, but docs out there are seeing Lp(a), aren't statins for everything, or should you not have used a statin in this case, or what's going on here?
Well, with the Lp(a), the statin therapy is not what we would use for that particular process in the first place, and the fact that it went up.
Meaning to lower
To lower
AUA mass,
Yes,
right?
yes. So looking at the result that he had, the lipid panel itself was excellent. Now, I don't know what it was before, but we do have that now when we took her
We
off
see
of it, and we
after,
see
right.
what it was, and she had some abnormalities there. The couple other parts that are here, this is the kind of patient that I'll describe as the 2 for heart disease, 2 against, as far as what numbers she's got. She's got high total cholesterol off medication and a high LDL cholesterol off medication, but she has an excellent HDL cholesterol, excellent triglyceride, and a triglyceride HDL ratio that's less than 1. So she's got parts of this that say she would have low risk and parts that say she would have an increased risk. So this becomes one that for me, there isn't any way to tell what her risk is going to be by the lipid panel alone. It's going to have to be what are her atherogenic ApoB particles.
That's for sure. And Tara, you can elaborate a little bit. Do you just say to women, wow, an HDL cholesterol 89, 90, you're fine, get out of here, none of this other stuff matters?
Yeah, we have to stop doing that because we recognize now that HDL is very complicated, and it's actually the functionality of the HDL particle that really matters. It's not about the cholesterol number itself. And so we can be very falsely reassured if we say, well, the HDL cholesterol is over 60, you don't have to worry about it. Those women end up in my office after they just had a heart attack or a stent placed. And I can tell you that obviously there are patients, women that have high HDLs, that have cardiovascular events, that clearly are at risk for other reasons, and or the actual HDL particle number itself may be low. The cholesterol's high, but the actual number of HDL particles is low. Ultimately, it's about the functionality, and we just don't know that. I mean, the HDL cholesterol really doesn't tell us that at all. But that's really new, and I don't think patients understand that. I think they've been taught by every women's magazine out there that if your HDL cholesterol is high, you're protected from heart disease. I think doctors have been taught in medical school for most of eternity that we, if that's there, we have protection from cardiovascular disease. And so I think there's a lot of misunderstanding about HDL. And I think we need to stop continuing to tell people that you have this magical protection as a result of your HDL cholesterol being over 50 or over 60.
Well, there's such a pervasive concept that the cardioprotective aspect above 60, that some people have kind of moved that into a realm of superpower, that it offsets the LDL cholesterol. And I've heard doctors use that word. If you said offsets to me, it would suggest that it negates the effect of the bad cholesterol, and therefore you zero out like nothing's going to happen, and that's so far from reality.
There's just no way to know. HDL cholesterol, that test is not a marker of HDL function. There's no relationship to it. And part of this misinformation, and maybe you could call it that now, but NCEP in the 2011 guidelines, which are now 11 years old, actually did call an HDL-C above 60 a negative risk factor, protective, and it's just not true. The HER trial, 2,600 women, serious coronary disease, 20% had significantly high HDL cholesterol. So never using that by itself tell a woman you're protected, or a man. I would tell you, you need further analysis, a better workup before you dare make that statement or so. So with the LP(a), is there any doubt that that is an important risk factor for people? Is that who should get an LP(a) level? It's a genetic test. Everybody one time in their life. Where do you use it in your practice?
I honestly have done an NMR and an LP(a) in every patient for more than a decade now, because I think everyone deserves a one-time analysis. LP(a) we know is associated with premature atherosclerosis. We don't have the outcomes data as whether we lower LP(a) specifically, do we reduce risk specifically related to that, but we know it's associated with premature disease. We know it's something that we need to pay attention to. So if we understand that that's part of the atherogenic milieu of the patient, we can target all other risk factors more aggressively, and potentially also address LP(a) with niacin, but certainly recognize the patient's higher risk, and especially if there's a family history present. I think it's real. It's something we need to pay attention to.
And it's an ApoB molecule, so anything with ApoB on its surface can contribute to atherosclerosis.
So maybe it's a worse ApoB molecule, perhaps, and the vast majority of your ApoB particles are LDLs, so of course it's going to be stuck mostly to LDL particles, but you could find it on some VLDLs.